All right, we have a really interesting case today. This patient was transferred to me late last night. I met him this morning. It's 2 weeks before the conference. I'd love to do this at the conference, but timing's not working. He was cathed about a month and a half ago. At that time, I had normal LV function. They found serious left main disease, but he's 90. Treated him medically. His LV function deteriorated over the last month. He was hospitalized for CHF, diuresed nicely, and transferred last night for a complex PCI. So the anatomy is pretty compelling, as you'll see. The right coronary is okay. Well, it's not okay, but comparatively speaking. I don't think there may be a target there, and approximately. There probably is, and that's worth exploring. But the real problem is here. As you'll see, the left main is very seriously involved, and we get better pictures of it. I really think that we're bailed out a little bit by that circumflex. There's a high diagonal or ramus, but the circumflex looks like it doesn't have much disease, so I think I'm going to get away with stenting right across that. The question is, how many wires should I put in? There's a lot of things to discuss. I mean, a lot of things. Should I use a rotablation? Should I use a Impella? The ejection fraction is 25%. I think probably Impella is a good idea. The problem I'm having with Impella is that the right groin, we did this from the radial. I've got a 7 French sheath in the radial. The right femoral, there's a lot of calcium right at the place where you would insert the sheath. The left is better, but there's tortuosity up above. I think you'll see here. So the left, I think the left would be a reasonable Impella case, and this would definitely be a reasonable Impella case. But the blood pressure is 140. And I'm hoping I can kind of just quickly get in there and get out. We put a 4 French sheath, as you can see. There is some tortuosity. I think an Impella would go through it, though. And you can criticize me if this doesn't go well for not putting Impella in. I think I would not criticize anyone for putting it in. But let me just see how this works. A little test there. OK, so again, I'm going to just feel this out. If it doesn't look like it's going well, we'll get an Impella in. You guys have the Impella in the room and all that, right? And my guide came out, it looks like, so I may test there. That's just me with your wrist. Is that bothering you? Yeah. This patient's a very cool guy. He's a pilot. He's a rocket scientist. Test there. He's 90. Yeah. I'm just bragging about you. Oh. All right, so we're going to put this wire. Test there. Where's that going? It's not going where I want it. So in general, if I think the lesion's not going to be too scary, I hold off on the Impella. Test there. It's not going where I want it, is it? Test there. Where is that going? That's going to go to this circ, right? That's the least of my worries, so let's not worry about that. Test there. It's going to a different kind of vessel. Let's see what it's going. I'm going to stop the camera for a sec. Okay, so we're in the spider view now. Test there. That's the circ, obviously. And I'm going to work on this and see what I can do to get into the lesion. I get across the lesion. Test there. Well, it's going to be harder than I thought, isn't it? Yeah, that's helpful, Shiloh. Thank you. And test there. Okay, so rather than you guys watch paint dry here, test there. All right, that's the diagonal. Okay, we got that done. All right, another BMW, please. I'm going to stop the camera again and work on this a little off camera, not to soak up too much of your time. All right, this was challenging. Just a BMW, but you can see it took a lot and to get this, but I finally got it through. All right, we're in good shape. I'm going to stop for a second and position the balloon. So this is really interesting. Just the wire passing through the stenosis is causing. Just take a little puff there, show how much flow we got there. See, there's not a lot of flow in the LED. I know I'm in a septal. I really want to get some more flow. I don't want him to get hypotensive on me. So I'm just going to take a 2.5 balloon in the left main and just do a quickie to get some more flow into it, and then I can relax a little bit. Can we hook that up? And then I'll get my wire down the LED and we'll deal with that as well. Okay, perfect. And here comes the balloon. Cross, test there. That should be good, right? Take it up there, 10.
1 up. 10.
12, 14. This is just a low pressure balloon. Down, down. We work quickly here. And 14 again. And down.
12, 14.
Down. Let's see if we have more flow now. If we do, that'll make me feel better. Inject. Okay, good. Much better flow. Okay, so let's take this out. So you know what, before we do that, give me the torquer on this. I just want to get that BMW down where it should be. All right, so we got the wire in better position. Test there again. I've got to push it down a little bit more. A lot of resistance. This is definitely an important lesion here in the mid-LED, and I'd like to get the left main done before I do that lesion if possible. I can't even get my wire to kind of, here we go. Now it's folded over. That's good. That's what I'm looking for. Good. Okay, so now we've got a 3.0 high pressure balloon. Test there. And we'll take it right about to here. Take it up there to 10.
Going up. We're at 10 now.
20. So we're getting full expansion. That's helpful.
20 now.
Down.
Down 20.
And then I'll just, again, I think that the body of the left main also is involved here. So take it to 20 again.
Going up.
And then I have to decide whether I want to, just go to 20 and then
We're at 20.
down. Then I have to decide whether I want to deal with the mid-LED now or after I have the left main stented. Probably the former. Inject. All right. So the balloon expanded, but it didn't do that much, did it? I'm in favor of putting a stent into the left main now. I think it has to be a 3.0. And don't take this off. I'm going to use this as a measuring stick. It's going to go back pretty much to the ostium. So let's just take a quick look here and put our balloon in and see how long a stent we want. If you want to go from test there, from about, well, probably there, right? Yeah, let's just send this. Inject. So, oh, you want to just do one really long one? Let's not. Because you can do one really long one and get the whole thing done with a 38. That's an interesting idea, isn't it? Problem is the LED, I think, should get more spot stenting. Oh, God, there's a lot of spots in it, though. All right, let's do the left main first, all right? We're all agreement. So that's 12, so that means 24-ish. All right, let's get a 24-ish by 3.0 stent. All right, so this is a 26 by 3.0 stent, and we are going to see if it goes. Okay, it goes beautifully. Test there. We'll bring it back to here. Maybe too short, huh?
Yeah.
Let's see. Don't move if you can. Inject. Actually, it's pretty good. That's what I'm looking for. Yeah, exactly what I'm looking for. I don't even mind that position. You know, I think that's it's back to the ostium pretty much. Test there a second. I think I should just take it. Let me do one more quick shot. This creatinine is good. Can come back just a little hair, right there?
Yeah.
Just a little bit. And test there. Okay. Take it up there, 10,
Going up. 60 and 10 now.
14,
14 now.
18,
18 now.
down.
Down 18.
Okay.
Stent deployed.
So that looks good. Let's see how it looks. So much calcium here. I wonder how many folks would have done atherectomy here, CSI, or rotablator. It's worth talking about. Ready? Inject. All right, so obviously things are looking up for this patient now. We've got all three vessels are filling. We're going to have to pot this 375, 40 for the left main. 40.
4-0.
All right, give me a 40, just an 8. Actually, just a 12. NC. And now we're going to do proximal optimization of this stent in the left main. I've chosen a 408 test there. I've changed my position. I want to see that circ, which is right there. Inject just a little bit. So this is good. Let's take it up there at 10,
Going up. 4, 6, 8, and 10 now.
20,
20 now.
and down.
Down 20.
Okay. Let's see what we've got here. And then we'll IVUS too. Hard shot. All right, so that's better. It's still not perfect there, is it?
A little bit in the proximal LED too.
A little bit what?
In the proximal LED, maybe taken up a little bit.
Yeah, well, let's do an IVUS quickly and see what we got. All right, so what's happened is here's the IVUS sitting in the ostium of the left main, ostium of the LAD. It was a little small there. Left main actually is really only a 3.5 to 4 millimeter vessel. It looks pretty good by IVUS. Could be a little bit better expanded. The next thing we're going to do is just take this, take a balloon and pre-dilate. We couldn't get the IVUS past the mid lesion, so I want to dilate that and get that stented. Okay, test there. And then we'll decide well, how far down to go? Take it up there.
Went up
Go to
460.
18. This is, how big is this balloon? 2.5, right? Or 2 1/4.
2
18, 20, and down. So I do this a lot. I take a 2 1/4 balloon. I'm not sure how big this vessel is. I don't want to get a big dissection. I just want to get it open. Take it up there again.
Went up
Take it up to 20.
8, 10, 12, 13, 16, 18, 20.
Look at that. That's 22.
22.
This is not opening, so that may need actually ablation. I don't like that at all. All right, down.
Down 20.
Okay, let's take this up again. This is a 3.0. Let's go up to, let's work your way. Let's go to 20.
275.
Let's do 2.75. Okay, 20. I want to see if I can get this to crack.
We're at 20.
Let me take that. I'm just going to go a little higher there. I got it to crack.
There it
Okay, that was at 26. And, oh,
I sent it.
it's in it. All right, good. So let's do that. Let's stay with this test there. I'm very happy now because I'm going to be able to get this done quickly. Let's take it up to 20 again. Go to 26. These NC balloons, I try them out on the back table, and they go to 30 down. I mean, calcium can change the rupture pressure, but usually we do pretty well. Now the next thing is, what do we do about the distal lesion? Let's test there. So you guys want to, everyone wants to put a stent down there too now, right? You basically want me to take a 38 millimeter stent and take it all the way back. I think I'm going to do that. I wish I had a panel to discuss it with, though. All right, give me a 2.5 balloon NC. Give me a 2.5 by 20 NC or 30 NC. We're making a vessel out of this now. Hope to hell it works. What, sir? We're doing, no, sir. We're doing such good work here, and we're probably 10 minutes from done. I want you to just think about something else. Think about flying that king. You have a lump in your throat. Blow up the balloon, you're going to feel that. That's your heart. Would it help if we wet your lips? Just hang in there with me a little longer. I'm definitely not. I don't want to do that either. And so far, the hardest part's already done. I'm now making everything look pretty, okay?
2.5, 30 balloon going in.
Okay, and the patient's losing a little patience on the table. He feels a lump in his throat from time to time. Test there. So that's obviously his angina. We're going to go down here. Take it up there, 10.
Went up.
And I want a 2.5, 38 stent.
We're at 10.
18. This is NC, right?
Yes.
NC, go to 20. Down.
Down 20.
We'll make these short inflations. And we'll do another one here. Go right up there to 20. Yep.
We're at 20.
Yep. All right, let me show you. I just used a 2 1/4 balloon, and we got that nice dissection down there. You see that? So I'm going to now stent this. I got a 2.5. Some people in the room think it should be a 2 1/4, but I'm going to take this test there. I think it'll be okay. That's about where we want to take it, right? We don't want to. We could take this all the way to the apex if we want. Inject. I think that's okay. You agree? Take it up 10.
Went up. 4,
And
6, 8,
then-
9,
Okay. 11. Down.
10, 11.
Okay, so the stent was deployed. Let's see, I took it to 20. I pulled it back and took it to 20. I'm very happy with that. Now I've got to go stent right across that diagonal. So let's pick a stent for that. Let's take it up here. Let's go up to 20. This is a 3.0, 26. We tried a 22, and it just was a little too short.
10, 12, 14, 16.
Yeah, it's going to be great. All right, down.
Down 20.
Okay, take a test here, inject. That all looks good. The diagonal's in shape here. I'm going to work a little bit more on the LED, on the left main, make that a little tight, a little bigger, and the LED itself, posterior LED. Okay. 20. Why don't you go to 24? Okay, this is the
320 is.
down 3.0 balloon in the ostium of the LED and the proximal LED, and we'll see how that looks. Inject. All right, so that's looking good. Now we just have to optimize the left main a little bit and do another IVUS. All right, so some of you may have noticed the slow flow in the ramus, so I am trying to wire that. Test there. I got it, good. So actually, the flow's coming back, but I'll just do a quick ballooning on that, like a 2.0. Do a quick kiss, all right? Make everybody happy. All right, so let me show you how this all ended up. As you can see, I'm trying to cross with a 2.0 balloon into that high diagonal ramus. I couldn't do it. Even tried the 1.5, but the flow kind of returned. And I could have spent more time on it, but the good flow in the ramus. He's getting antsy on the table here. I mean, he's really talking to me, and he says, I really want to be done with this now. So this is, what you'll see here is a 4.5, 4.0, and then we IVISed, and I just thought it could be a little better, so we did a 4.5. It's pretty good, though. You see, I just felt a little better than that, so I went ahead with after this is IVISing, and did a 4.5 balloon finally when I finished IVISing. And you'll see there's the 4.5. And we're almost done, sir, just a minute or two more. And that's our final results, which I was very happy with. This view, you see a little bite in the calcified bite in the inferior margin of the left main. You don't see it in the other views. I think the LED looks good. I think we helped them a lot. This is a lot of good. I want to show this case at the conference. I'm hoping we can show it and talk about it, because there's a lot of things I think to discuss on it. Should we have done rotational atherectomy? Should we have done double stent in the left main? By IVIS, that left main looks really good, though. It looks solid, looks wide open. So I'm really, really happy with this, and I'm just going to quit here. We did it radially, which is nice. We have a 4 French sheath for a possible impella in the left femoral artery, but we haven't had to use it. So it's kind of cool with a 90-year-old. We can do this. He does not want me to do the right now. He's told me that very clearly. So we'll do that in a day or two or a week, whatever. All right, thanks.